Hi guys, let's clarify questions concerning primary amenorrhea that confused you. So you start always with definition, that's why I take pens, papers, and let's fix it. Actually, pens and papers you need also for making the notes. So primary amenorrhea is defined as the absence of menarche, the first menstrual period, by age 15, in someone with normal growth and secondary sexual characteristics, or the absence of menarche by age 13 in someone with no secondary sexual characteristics like breast development. So the two phases of too late. So why puberty status dictates the primary amenorrhea clock. This refers to the dual age criteria based on a secondary sexual characteristics. What does it mean? The definition itself has two distinct age criteria based on the presence or absence of secondary development, that is puberty. Okay? Sexual development is a puberty. So why it's so important, my beloveds? Clinical issue. This dual definition is crucial for determining when to initiate a workup. Evaluating a 14-year-old with no breast development, that is tender stage 1, is appropriate. Whereas evaluating at the same age 14-year-old lady with normal breast and pubic hair development, tender stage 4-5, might wait until easily age 15. So it tailors the investigation timeline to the individual's pubertal progression, preventing premature workups and unnecessary workups, while ensuring timely diagnosis for those lacking pubertal development. Okay? Next, the usual suspects. So navigating the common cause from chromosomes to canals. This refers to, my beloveds, this question refers to gonadal dysgenesis and Mullerian agenesis as a frequent causes. What does it mean? The most common cause fall in two distinct categories, but gonadal dysgenesis, often Turner syndrome, and Mullerian agenesis, Mayer-Rokitansky-Kastler-House syndrome, just Mullerian agenesis, frequently top the lists, highlighting issues from chromosomes, chromosome problems to anatomy. About Mullerian agenesis. Actually, Mullerian agenesis, or more precisely, Mullerian aplasia, is the underlying development defect that caused this Mayer-Rokitansky-Kastler-Hauser syndrome, MRKH. So why is so important? Knowing the common cause directs the initial diagnostic approach. A systemic evaluation usually involves assessing ovarian function, FSH, follicle stimulating hormone, luteinizing hormone, LH, estradiol, pituitary function, prolactin, thyroid stimulating hormone, TSH, performing a karyotype, and imaging the pelvic anatomy, usually via ultrasound. Okay, so this structure approach efficiently, narrows down the broad differential diagnosis. About FSH, actually, the great divide in the diagnostic pathways, the great divide. So, refers to follicle stimulating hormone levels, differentiating ovarian failure from other causes. What does it mean? A simple blood test that for FSH is a powerful differentiator. High FSH strongly suggests ovarian, gonadal failure, with low or normal follicle stimulate hormone points towards hypothalamic, pituitary causes or outflow tract issues. Why it's so important? My beloveds, this is a key branching point on the diagnostic algorithm. High FSH, hypergonadotropic hypogonadism, prompts the high FSH prompts immediate karyotyping to check for Turner syndrome, Swyer syndrome, gonadal dysgenesis, or other chromosomal abnormalities causing premature ovarian insufficiency. Whereas low or normal FACH, what is this? Hypogonadotropic hypogonadism or eugonadism. Hypogonadotropic hypogonadism or eugonadism. Suggests central causes like functional hypothalamic amenorrhea, Kalman syndrome associated with anosmia, pituitary tumors, for example, prolactinoma, craniopharyngioma, or constitutional delay. If secondary sexual characteristics are present, it also raises suspicion for outflow tract obstruction, for example, Mullerian agenesis, and perforate hymen, where hormonal axis might be quite normal. Next, actually about puberty present. So puberty present, uterus absent. Solving the Mullerian agenesis versus complete androgenal insensitivity syndrome. So refers this question, puberty present, uterus absent, refers to the specific clinical scenario pointing towards Mullerian agenesis or complete androgen insensitivity syndrome. What does it mean? The combination of normal female secondary sexual characteristics indicating estrogen production, but an absent uterus on examination, ultrasound, dramatically narrows the diagnosis to primary two conditions: Mullerian agenesis or complete androgen insensitivity syndrome. Why it's so important? This specific scenario demands a karyotype. A 46XX karyotype confirms Mullerian agenesis, congenital absence of uterus and upper vagina. A 46XY karyotype confirms complete androgen insensitivity syndrome, genetically male, but tissues cannot respond to androgens, leading to female external phenotype. Tests are present internally. It's actually a rare phenomenon, but it happens. So differentiating is critical for management. For example, vaginal dilation, creation for Mullerian agenesis, gonadectomy for complete androgen insensitivity syndrome due to malignancy risk actually in undescent tests, long-term hormone replacement therapy. Okay? Rare phenomena, but happen. Now, if you receive questions like this, okay. Now about functional amenorrhea. More than just stress, my beloveds. Functional amenorrhea. Functional amenorrhea reach into primary cases and bone health. So refers to functional hypothalamic amenorrhea misperiods presenting as this misperiod and its implications. Functional hypothalamic amenorrhea, often related to stress, of course, excessive exercise, low body weight, eating disorders, as a common cause of secondary amenorrhea, but we will talk about it. We used to talk about it, but by the grace of God, we'll talk again. But can also present as a primary amenorrhea if the trigger occurs before menarche. It's a diagnosis of exclusion. Okay, remember that. So why it's so important? A thorough history focusing on diet, exercise, stress levels, of course body weight changes is crucial. While common dysfunctional hypothalamic amenorrhea requires ruling out more serious underlying pathology like pituitary tumors first, of course. So rule out more serious underlying pathology first, then talk about just functional characteristics. So management involves addressing the underlying cause, nutritional rehabilitation, modifying exercise, stress management, and so on. Importantly, the associated hypoestrogenism carries long-term risks like impaired bone density cohesion, failure to reach peak bone mass, necessitating monitoring, for example, dual energy X-ray absorptiometry, DXA scan, and potential, why not, hormonal replacement therapy. Now about the cycle, how pain can unmask an obstructed outflow tract. So it refers to pelvic pain suggesting anatomical blockage like imperforate hymen. Anatomical outflow tract obstructions like an imperforable hymen or a transverse vaginal septum can cause primary amenorrhea, missed periods, with cyclic pelvic pain as menstrual blood accumulates hematocolpos or hematometra. The presence, so why it's so important, the presence of cyclic monthly lower abdominal pain in an adolescent lady who hasn't started menstruating but has normal secondary sexual development should raise high suspicion for an outflow tract obstruction. Physical examination, bulging hymen, and pelvic ultrasound are diagnostic. This is often a surgical correctable condition, and timely diagnosis prevents complications like retrograde menstruation leading to endometriosis, pelvic adhesions, or infection. Next question is about syndromic nature of primary amenorrhea. So it refers to associated health issues in the conditions like Turner syndrome or Mullerian agenesis. Many causes of primary amenorrhea are associated with other significant health issues. For example, Turner syndrome, 45X, has associated cardiac defects, coarctation of the aorta, bicuspid aortic valve, actually we don't know why. Renal anomalies, autoimmune disorders, especially thyroiditis, and hearing loss. So, Mullerian agenesis often has associated renal, for example, unilateral agenesis, and skeletal anomalies. Why it's so important? So diagnosing the cause of primary amenorrhea necessitates a comprehensive evaluation for associated conditions. A patient diagnosed with Turner syndrome requires cardiac and renal screening, regular thyroid function tests, and audiology assessment. A patient with Mullerian agenesis needs a renal ultrasound. So this syndromic approach ensures holistic patient can care beyond just managing the amenorrhea. Holistic approach always okay. Okay, about bone health, of course. So refers to the impact of hypoestrogenism on achieving peak bone mass. The lack of estrogen exposure in many forms of primary amenorrhea, missed periods, especially hyper or hypogonadotropic hypogonadism, significantly impacts bone health, preventing the attainment of peak bone mass during adolescence. So why it's so important? This has major long-term consequences, increasing the risk of osteoporosis and fractures later in life. So BMD, bone mineral density assessment with DXA scan is often indicated. Timely initiation of hormone replacement therapy with estrogen and progesterone if uterus is present is crucial not only for inducing and maintaining secondary sexual characteristics, it's okay, but also critical for promoting bone accretion and mitigating long-term skeletal risks. About psychological impact, my beloveds. This refers to the emotional identity and fertility concerns associated with diagnosis. Of course. So the psychological impact of primary amenorrhea diagnosis can be profound, affecting body image, sense of self, peer relationships, and causing anxiety about future fertility and sexual function. So why it's so important, my beloveds? So healthcare providers must approach the diagnosis and discussion with sensitivity and empathy. God bless you. Providing clear explanations addressing concerns about fertility potential, which varies greatly depending on the cause, discussing managing options, including hormonal replacement therapy, surgical correction if needed, potential for assisted reproductive technology, who knows, and offering psychological support or referral, offering a psychological support and the referral are essential components of comprehensive, normal human care, if you want. A multidisciplinary team approach can be very beneficial, as always. So that's largely sufficient. I suppose I clarified all these questions. So the rest are about secondary amenorrhea. By the grace of God, we will discuss it later. Stay blessed. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as my Telegram channel, Dr. Y. W-H-Y. Dr. W-H-Y. Like question. Dr. Y. You type in searching mode in Telegram Dr. Y. You click start. Then you choose your plan. Stay blessed.